caused by the President's health care law. Thank you, Mr. President. I yield the floor. And note the absence of a quorum.
Clerk will call the roll.
Mr. Alexander.
The Senate this afternoon working on the nomination of Mel Watt to head the Federal Housing Finance Agency. The Democratic congressman was tapped by President Obama in May to lead the agency that regulates mortgage financiers Fannie Mae and Freddie Mac. We expect a final confirmation vote on his nomination this afternoon. Earlier today, Minority Leader Mitch McConnell attempted to overturn a change the Senate made to its filibuster rules last month, which lowered from 60 to 51 votes needed to advance most judicial and executive nominations. The maneuver was rejected by Democrats. The Senate then went on to confirm Patricia Millett to be a judge on the U.S. Circuit Court of Appeals for the District of Columbia, making her the first judicial nomination of President Obama's to clear the Senate since Democrats changed the rules. Patricia Millett was confirmed with a vote of 56 to 38. The Senate now in a quorum call. While we wait for a senator to speak, here's a look at U.S. hospital costs from this morning's Washington Journal.
Is a former ER doctor who now works as a correspondent for the New York Times, and she's also the author of the latest piece, As Hospital Prices Soar, a Stitch Tops $500, and she'll be discussing that article with us today on the last 45 minutes of the Washington Journal. Ms. Rosenthal, the article is about the notoriously opaque world of hospital charges. Give us a sense of how much of healthcare spending hospital charges we're talking about here.
Well, there are recent estimates that 40% of healthcare inflation over the past 10 years has been from hospital charges. So it's a really big part of the problem, and if we want to control spending, we really have to deal with it.
And in your piece, you took us through some experiences that some folks had in going to the hospital and what they were charged for. How do hospitals determine their prices for different services at a hospital?
Well, they basically price what they want and what they can. And if you're a hospital that has a big market share or you're a brand name in a certain city, you can pretty much charge what you want. You know, the bill goes to the insurer, first of all. If the person is insured, people may look at it and go, as the patients in the series did, wow, you know, $3,000 for a few stitches, that seems outrageous. And it's not until people start having to deal with their co-payments or co-insurance that they really get upset. So it's a very weird kind of market because a lot of people don't pay for the majority of their health care.
Well, you brought it up, but let's put a face on this experience. Talk about Orla Roche, who you interviewed for this article.
Yeah, well, Orla was actually the kid, so she was 2 years old. She didn't have much to say about it other than it hurt. But the mom, you know, they were on vacation in San Francisco. They're New Yorkers. She fell off the couch. The daughter fell off the couch. She's a kind of rambunctious toddler. Hit her head, and of course, what are you going to do at that point? You're not going to call around and look for a good deal. You take the kid to the ER, which they did. They took her to the ER at California Pacific Medical Center, a good hospital in a nice part of San Francisco. And, you know, empty Saturday, they put some glue in the wound, calmed the kid down, put a big bandage around her head, put a sticker on it, and they left happy. You know, they thought, wow, this is great. They're good DVDs. The nurses and doctors were really nice. Until Amer Duffy, Orla's mom, saw the bill, you know, of close to $2,000. And plus, I think the reason we're hearing about this more and more is because, like many Americans, they are facing rising deductibles and copays. So they were stuck with about half of that bill for something that was really minor.
You say stuck with half of that bill. Talk about the role that insurance companies play here between what hospitals charge for and what you end up paying.
Yeah, well, hospitals always say, oh, yeah, those prices look ridiculous, but the insurers all negotiate with us and we end up settling for less. So many insurers have contracted rates for predicted services with hospitals. So they may say, okay, your bill is $2,000, we're going to pay 70% of charges. So they may say, okay, the reasonable price is $1,600. But then you have to look at the patient, how that insurance works for the patient. And their insurance may say, okay, you pay 20% of that, or you pay the first $1,000. So if the negotiated rate is still high, patients can face really significant out-of-pocket costs, and more importantly, we're all paying in the end with higher deductibles. And the people who are worst off in this, of course, are the people who have no insurance or paying for themselves because they don't have an insurer even to reduce that initial high bill.
And to illustrate the point, you looked at some of the price markups for California Pacific Medical Center,
yeah.
What they charged for different products and services and what the market price was. Tylenol with the codeine pills California Pacific charges $36.78. The market price there, 50 cents, according to your reporting. IV fluid bags, California Pacific charges $137. The market price, under $1. What is the explanation from a hospital like California Pacific Medical Center on these markups?
Well, every hospital will say, look, we do all of these important things for the community that we don't get compensated for. You know, we have nurses around, we have to heat these buildings, maybe we go out and do some health fairs. We are a benefit to the community, and we have no way to charge for that. And there are all these people who don't have insurance or have, you know, Medicaid, which doesn't pay us our costs. So we have to do a lot of cost shifting. But there's really no science in this, you know, so how much cost shifting really goes on? What's the right amount to pay for medical care? And, you know, in the series we've looked both to variations within the U.S. You know, you realize that if a really strong academic hospital can do it for half that price, then maybe everyone should be able to do it for half that price. And then you again look overseas to some of the you know, high-quality European healthcare countries, and you see that they're doing it for sometimes a quarter to a fifth to a tenth even of the price we're paying. So if they're doing it that way, well, why aren't we? What's the problem with the way we're delivering healthcare?
We want to hear from viewers on this subject. Elizabeth Rosenthal of the New York Times is joining us to take your questions and comments. We want to hear your experiences at the hospital. What aspects of what you were charged for hospital care were unexpected to you? Call in. Our phone lines are open. Republicans can call at 202-585-3881. Democrats, 202-585-3880. Independents, 202-585-3882. And if you're outside the U.S., it's 202-585-3883. We'll also take your comments on Facebook and Twitter. And while folks are calling in, Elizabeth Rosenthal, is there anybody in the federal government or state governments who's in charge of regulating these costs to ensure that people don't get gouged for some of these charges?
Well, the one place we really, well, Medicare does set inpatient rates. So you'll hear a lot of complaining, and Medicaid. So you'll hear a lot of complaining from hospitals that, well, those don't cover our real costs. But what's the real cost of the hospital? I think that's what we have to ask. And also, no one regulates the cost of and pricing of medicines, which is a big burden for patients because prescription drug coverage often is not as good as general medical coverage. So I think there are a few parts of the federal government and that do this, but I would say one way that we really differ from every other country in the world is that we don't have a national mechanism for price regulation, and that puts us at a great disadvantage in getting good costs because we have, you know, hundreds of hospitals and hundreds of insurance plans negotiating separately for rates. But you can imagine if you had the power of Medicare or the federal government to say, as every other country does, we're not paying more than this for this new drug, you would certainly get a much better price. The VA does this, and the VA tends to get much better prices on medicines than the rest of the country.
Several folks waiting to chat with you. John's up first from Goffstown, New Hampshire, on our line for Independence. John, you're on with Elizabeth Rosenthal of the New York Times.
Yes, good morning. I'm retired, been retired for about 10 years. I have not the opportunity, but the experience of being in the hospital about 3 times in the past 10 years, short term. And I noticed that the bills every time, what I ran into now is that hospitals are charging a $250 process fee to let you leave, administration cost. And then on top of that, they tell a doctor comes in and says you're going home tomorrow morning. You get up, you can put your clothes on, you sit on the side of the bed, and you don't get released until after like 11 o'clock, like the motels and everything use. You have to be out of the room by 11, or you're going to be charged again. I think they're double dipping as far as I'm concerned. You know, I mean, if the person could be, be discharged, let them be discharged. But I think they're trying to double it up, and when they got an empty bed, they're charging Medicare.
Elizabeth Rosenthal.
Yes, I mean, I've seen, you know, since I started this series, I think I've seen every medical bill at the New York Times, and it's been really eye-opening. I think you see a lot of what one consultant who commented on the article said is called strategic billing. You know, hospitals hiring big consulting firms to say, how can we make more money from what we do? And that's really distressing to patients and to a lot of doctors when they see how their services are being billed. So there is a lot of, you know, I spoke to one man last night who was taken by ambulance to an emergency room as trauma, even though he didn't really have very serious trauma. He was in a minor crash and his back hurt. Going into an ER by ambulance as trauma set off this $10,000 trauma activation fee. Now, what's that about? You know, if you call a European hospital and say, what's your trauma activation fee, they'll go, what are you talking about? You know, we don't know what that means even. So yes, there's like the discharge fee. Well, what's that for?
Myland on Twitter writes in about his experience. I had an MRI, cost $4,500. Insurance negotiated it down to $800. I paid $160. We want to hear from our viewers in this segment of the Washington Journal this morning about your experiences and what surprised you about your hospital bill. But Elizabeth Rosenthal, question for you. What about the argument from hospitals that these markups that we've been talking about are needed to cover some of the charity cases that come in through the door where they don't get paid?
And I think some of that is valid. You know, one thing that the Affordable Care Act in theory will do is once everyone has the availability of insurance, then hospitals presumably will do less what they call charity care, and as a result their payments for charity care are slated to decrease over the coming years. But you know, when you hear something like they charge $4,500 and took $800, well, you know, hospitals aren't doing that much charity care. The New England Journal recently looked at how much charity care some of these hospitals were doing, and they came out with a number of, you know, 7.5% or so. And that includes, that's not just, you know, free care, that's money lost by treating the low cost they get for treating Medicaid patients. So I think there are a lot of economists and accountants who would say, okay, fine, if we're going to say we're going to compensate for charity care, let's have a rational system for doing it. Let's be clear about how much is really done and deal with this in a rational way. I mean, how could you remodel a kitchen if your contractor came in and said, you know, I'm going to charge you $20,000, but in the end took $4,000? I mean, that's just, you can't run a market-based system, which is what we're trying to do in that way.
And some of these hospitals are getting tax-exempt status for some of these charity cases. How much money are we talking about in tax exemptions for some of these hospitals that you looked into?
Well, you know, it's very hard to know for any individual hospital because you have to remember they don't pay real estate tax, they don't pay payroll tax, they don't pay federal tax, they can issue tax-free bonds. There was an estimate, there was an estimate in about 10 years ago that the overall value of those tax exemptions was something like $12 billion. So it's a lot of money. You know, there are ways that they are being compensated for charity care already. And most hospitals in the U.S., as you note, are nonprofit.
Clara is up next from Murfreesboro, Tennessee, on our line for Republicans. Clara, you're on with Elizabeth Rosenthal.
Good morning. Unfortunately, I have a lot of practical experience. I have a son that's had cancer 4 times, and my husband's been in and out of the hospital 8 or 9 times in the last 2 years. I believe that some of these hospitals, for lack of a better word, are in cahoots with home health care if they don't even own their own health care departments, home health care departments. And a lot of the baby boomers are opting for in-home care rather than going to rehab services. And I can tell you that the quality of care in a home health service that the hospitals are sending these patients home to is not always first class. Some of the patients, some of the people that have been in my home, I don't even think that they have any medical experience at all, and we had a very horrible story, which I won't go into. But I think that the hospital should present you with a bill as soon as you check out, because everything is on barcode. There's no reason that they can't give you at least an estimated cost of what it's going to cost you when you check out, just like the other gentleman said, when you are in a motel.
Elizabeth Rosenthal, let you jump in.
Yeah, I think what we see and what you're referring to is more and more of hospital care. It's very fragmented, right? So there's a lot that's outsourced. The hospital doesn't do its own home health care, so there's another company, often for-profit, that's doing that. You know, the dialysis may be outsourced, for example. You go to an emergency room. In most cases now, the emergency room doctors are a separate bill. They're doing their own billing. So the hospitals will say, well, we can't provide a bill for you because we've outsourced, you know, X, Y, and Z, and really what the hospital bill is about is only a part of your care. And I think that's really problematic for patients. You can imagine, and you know, with the analogy to a hotel bill, you know, oh, well, this is just the bed charge. You know, you're going to have to wait and get a bill from our outside contractor for you know, using the health club, and you're going to have to wait and get another bill from housekeeping because that isn't something, you know, that's included in our normal charge. It's really, really problematic. And if we want people, as we say we do, to be better consumers of health care so we can maintain a market-based system, there's got to be more price transparency. And I would say not even right when you leave the hospital, but how about before you check in? How about having price lists that people could look at and say, you know, and doctors, you know, doctors when they refer you to a hospital have no idea often what you're going to be charged. So maybe my internist would look at a few hospitals and say, you know, this one is much better value, I'm going to send you there, and I would be fine with that.
What would your recommendation be, though, for people in an emergency situation? You know, how can you shop around for a hospital if you're in an emergency situation?
Well, you can't and you shouldn't have to, right? You know, when, first of all, an ambulance is going to take you where they want to take you more than where you want to be taken, often based on your injury and sometimes, though, based on business relationships, so it's often not that straightforward. I guess you know, this sounds crazy that I think people should have to do this, but I would know which emergency rooms and which hospitals are in your network, so you kind of know where to go. But, you know, it is crazy. One of the patients in this story on ER Care described she was in a soccer game. She got knocked out, cold, unconscious. When she came to, a friend drove her to the emergency room, and on the way to the emergency room, she was Googling on her phone to figure out which was in network. And, you know, they went to the one that was in network, and, you know, as I said in the story, she was really glad she did, because at the in-network hospital, there was a negotiated rate that was much better. But it's a little crazy that people have to do that. And prices are very hard to, actual prices, though, are very hard to find in advance. And I should kind of, you know, kudos to California. The reason partly we went there for this story is, unlike most states, unlike I think all other states, California requires hospitals to publish their charge masters, their master price lists. They're not in a place that they're very easy to find. You know, they tend to be hundreds and hundreds of pages of entries, like, you know, $37.98 for a Tylenol with codeine, but at least in theory, they're out there. Now, I guess the next challenge, if we want to be good consumers, is those master price lists have to be transformed into something that, you know, an ordinary human being could read in a reasonable amount of time.
Let's go to Wisconsin now. On our line for Democrats, Norman is waiting. Norman, you're on with Elizabeth Rosenthal of the New York Times.
Good morning. Yes, earlier in the program, she was...
Go ahead, Norman. We can hear you.
Oh, I'm sorry. Early in the morning, she was speaking of, you know, the hospital fares and so forth. And the only hospital fare that I've seen around here is when they're out trying to get donations for blood. And that's a good thing. But you never see our hospitals around here doing a hospital fair to try raising any kind of cash or anything for any kind of donations. I was in the hospital 2 days, 16 grand. They did 36 blood tests on me for exactly the same thing. And I negotiated that down. I said, this is ridiculous. The $16,000 for 2 days. Actually, a day and a half. I got out at noon.
Norman, how long did it take you to negotiate that down, and what were your strategies when you were doing that negotiation?
Well, I walked in, and first off, I told the attending doctor, I said that I wasn't going to pay this. And I said it was ridiculous, and now it was outrageous. And then I went to the office and had a little chat with the representative there, and I said, I've been here a day and a half, and I had a slight case of pneumonia. All right, they gave me medication and an IV. Okay, and one shot so that there was no clotting of the blood. Okay, and then they just started drawing blood, and they had just numerous times they come in and they kept taking blood. And come to find out, it was all for the same thing. They just wanted to check my blood, check my blood, check my blood.
Norman, thanks for sharing your experience from Wisconsin. Elizabeth Rosenthal, let you comment on Norman's experience.
Well, I'm wondering if he has insurance. I think it's really good if people with insurance are starting to negotiate these bills and say this is outrageous. One thing that I would comment on is for many hospitals, things like blood tests and X-rays, they are the money makers. They're like the booze in a restaurant. They're their big markup items. So you do see, and of course, you're in a hospital, a doctor says you need to have your blood taken. You're not a purchaser, really. You don't have a choice, and you don't know how much it's going to cost. And what you see is often very ordinary blood tests marked up that a national lab would do for $10 being billed at hundreds of dollars. One thing I really love, most lab machines do the basic electrolyte panel. It's automated, so it's all done at once. It's sodium chloride, BUN, and creatinine. It's all done as an automated thing. But a lot of hospitals pick out each of those items and charge separately. So it'll be $70 for the sodium, $69 for the chloride, even though it's essentially one test they're doing. But and we call this unbundling. It's a strategy for making more money.
James on Twitter calls for emergency room reviews, just like restaurant reviews, using stars and dollar signs. Catherine's up next from Monteagle, Tennessee, on our line for Democrats. Catherine, good morning.
Good morning. Ms. Rosenthal, I've read that United Health Insurance is buying physician groups all over the country, and they're dropping many of those physicians in that network that they buy from their network. And I'm wondering, how is United benefiting from this, and how are doctors and patients suffering from this?
Well, we see this in a lot of the country. The big game before has been negotiation between hospitals and insurers for rates. And the doctors have kind of been in the middle. But now what we're seeing more and more is that hospitals or insurers are basically allying with doctors' practices, because doctor referrals are obviously the primary source of business. I think what's unfortunate for patients in the end with these kinds of arrangements is that you have these big almost monopolies in some parts of the country, and they have tremendous control over price and how medicine is practiced. Order more tests, refer the MRIs to this guy in our group rather than this other guy who may be cheaper and better on the outside. One group I hear a lot from, people who are really, really distressed, are primary care practitioners who, in this big kind of commodification, I call it, of health care, they don't have a lot of market power, and yet and they're really struggling because they have no bargaining power. They have to take whatever rates they get.
Can these
it's
large
now
groups
kind
that
of-
you're talking about, these large hospital groups, create economies of scale and in some ways help lower prices? Are you seeing that?
Yep. Well, sure, if they want to, they can. You know, I think it depends what your goal is in taking on these physician practices. If your goal is to try and make a seamless system, that can happen. I mean, you look at, you know, an HMO like Kaiser, where everyone is on salary, we're all in the same system, doctors and hospitals. It's very efficient. But if you're, in a lot of these cases, the doctors aren't being put on salary, so the private incentives still exist. But they're relying as more of a business strategy so that the insurers can control more of the market. And one of the reasons California Pacific Medical Center was able to charge these high charges in San Francisco is it has tremendous power in Northern California, to a point where it's being challenged now with some lawsuits about its market power and practices.
David's up next from Richmond, Virginia, on our line for Independence. David, good morning to you.
Good morning.
Go ahead.
So I've heard several things, but one of the things that I think predominates is the ability to negotiate. And I've been told by several people that because of the negotiated rates that the insurance companies get, that you as an individual cannot then go back to the hospital and say, you know, look, you billed me excessively for this particular procedure or something, and then negotiate yourself. I heard a previous caller indicate that he was able to do that, and I think that if people were able to do that on a line-by-line basis, and then you would actually have what I think you're alluding to is a market-based, you know, supply and demand for medical practice. That, I think, is really where it's at. A quick little vignette: my grandfather in 1960 had a heart attack, and he had no money. He was poor as dirt, lived in a trailer, had no money. They took him in Hall County, Georgia. They took him in to the hospital, treated him. He was in the hospital for almost 3 weeks. He negotiated a bill with them that came out to about $3,500. He actually worked with some of the physicians. He was a bricklayer. He laid brick for them. He worked on their homes, and he paid that off. But for some reason, we have gone into this concept that we want to isolate people from having to worry about that sort of thing. And I think that if we went back to something like that, where people, whether it was him, you know, bartering his work or simply negotiating a fairer price for the items rather than being billed for items or things that did not happen. Anyway, I think that's all I have to say.
David, thanks for telling your story. Elizabeth Rosenthal.
You know, there is very variable ability and room for patients to bill. You know, it's like a bazaar where some stands you can do a lot and some stands are really fixed on price. There is a component where if you have insurance and the insurance has set a negotiated rate, the patient copay is supposed to be set, because the idea of that is that it's that copay that prevents you, that makes you a little price sensitive. And if the hospital or the pharmacy says, okay, our negotiated rate is $100 and you're supposed to pay $20, but we're going to forgive your copay, that's not legal. So, you know, although there are a lot of ways that pharmaceutical firms are getting around that, providing copay coupons. But part of the idea of a patient copayment is to make people price conscious. You know, that being said, when the starting point of prices is so high now, and the insurer negotiated rates are high, you can understand why people want to negotiate further, because, you know, if I'm left with, you know, as patients in the story were, $1,200 for a minor ER visit, that seems outrageous to me, and I don't have the money to pay for it. I'm outraged. Maybe I do have the money, but I'm just kind of morally outraged that it should cost so much. So I do tell people that they should try and negotiate, but a lot of hospitals won't go there, and you see a lot of people facing bill collections and long-term payment plans to pay for things because they don't negotiate and because they can't negotiate. I mean, the people who can negotiate are people who don't have insurance. I spoke to one guy last night who was uninsured, and he got a bill for something minor in an emergency room for $3,000, and they said, and he said, I'm just not going to pay it. You know, this is what I'll pay you, and he could work something out. So, you know, ironically, if you're uninsured, you have more room to negotiate than if you are insured, because in theory, if you're insured, your insurance has done that negotiating for you, but often they're not really good negotiators.
On the question of charity work by hospitals, Demental asks on Twitter, how much in money were lost? How much money was lost due to immigrants using the ER as primary care? Did this cause the increase in fees to recover revenue?
Well, you know, that every hospital will tell you that, and that's certainly a component of what they do. They, you know, emergency rooms take everyone without regard to their ability to pay. You know, that's the right thing to do. You know, but when they say charity care, don't be fooled, because many of those people are being billed and are being pursued by bill collectors. Now, hospitals won't collect a lot on, you know, people who have no money, or so they don't make a lot. You know, they're not making money. They are losing money on that. But you know, and again, once Obamacare is fully deployed, a lot more people will have insurance. That amount should go down. But again, you know, there are many health economists, I think most health economists, who feel like that alone really doesn't go very far to explain the really high bills we see.
Several callers waiting to talk to you. We'll try to run through them quickly here. Brett is from Corpus Christi, Texas, on our line for Republicans. Brett, you're on with Elizabeth Rosenthal.
Good morning. How are you all doing this morning?
Good. Go ahead.
I wanted to add something to the discussion that is, I think, completely missed. I have my own medical issues, but what's something that I found out just recently is when the hospital is providing you with this enormous invoice, let's say $40,000 for round numbers, and then your pre-negotiated cost through your healthcare provider gets you to a place of $10,000. The reason, one of the main reasons the hospital has the bill so high, they know that they're not getting that money. There's a tax implication with it. They take the $30,000, the difference between what they're being paid and what they're billing, and they call it a loss. And what it is just an arbitrary made-up number to generate a big loss for the hospital. Now, I do understand most of them operate on a nonprofit status, but it is a technique from a CPA's perspective, and I'm telling you that is why they inflate the bill so drastically.
Elizabeth Rosenthal.
Yeah, there are a lot of I mean, and that's the problem in a way. There are a lot of motivations to increase the bill to levels that everyone knows are not realistic. You know, the hospital executives will tell you, oh, we never expect to get this. One of them is you can exaggerate, if that's the right word. Maybe that's a little too judgmental, but you have this big chunk of care you can call charity care for some tax purposes. That you can't do that with people who have insurance, but you can do write-offs for Medicaid that way. The other thing is, you know, a lot of insurance contracts stipulate we'll pay, the bargain rates that insurers arrange is we'll pay 60% of charges. So how do you make more money? You say the charges are higher. You know, the incentives are to do this. So I think, you know, I spoke to one health economist who said, we get exactly the kinds of charges you would expect given the incentives that are at play in this system. And we wouldn't tolerate this in any other kind of market that we deal with on a day-to-day basis, and particularly not for one that's so vital.
John in North Carolina says on Twitter, hospital pricing is a perfect example of what results when a service is not part of the free market. Paul's up next from Morgantown, North Carolina, on our line for Democrats. Paul, good morning.
Good morning. I'm so glad that you're having this topic on here in regard to the price in the hospitals. I've just recently, as a matter of fact, I'm recovering from an accident, farm accident, where I had a bone crushed, and it happened on a Saturday afternoon. And I was taken in, kept for 3 days without seeing a doctor, not even given a drink of water until they've got their trauma doctor in to deal with my injury. And at that time, he came in, done a surgery. I was kept another day and a half and let go. I was billed for 5 days. The first 3 days, they never done a single thing. I laid in a bed. They billed me $71,000. When I got to looking into the bill, they were charging $35 every time the nurse walked into the room. And after the surgery, any pain medication I got, if it was a pill, it was up as much as $30 to $50. If it was an injection into the IV, it would be over $100, and this whole bill was just ludicrous. There was no way to justify this, and they're doing it with everyone. And the gentleman that called and talked about the false number, that's exactly true. Industry does the same thing. They say, well, we want to meet this demand, and then if they don't meet it, it's an arbitrary number. If they don't meet it, they call it a loss.
Paul, did you try to negotiate on your bill at all after you left the hospital?
I'm still working. I'm still trying to determine how much of it that I'm going to actually pay, because I may go to jail before paying it. That's how upset I am about it. And I worked in law enforcement, and I've always been a straight-up, hard-working citizen. Always paid my bills, paid my taxes. But I'm upset enough about this to stand the line and go to jail over it if I have to. It's that wrong.
Elizabeth Rosenthal, I'll give you a chance to comment.
Yeah, you know, I've heard this kind of reaction from a number of people now, that, you know, I am so outraged about this bill that I, you know, let them come after me. Let them do what they want to my credit score. You know, this gentleman, I'm going to go to jail, $71,000 for a farm injury. That's, you know, that's a lot of money. And there's, you know, you look at the bills, and that's where people get really upset because they see what they're being charged for. So, and I, you know, to his point about not being seen for a few days, I think traditionally we Americans have liked to feel like, oh, the reason it's expensive is because we have the best medical care in the world. And, you know, there are great hospitals in the U.S., but there are great hospitals doing the same quality of care in other countries for a fraction of the cost. And the studies have repeatedly shown that our high prices do not give us better care. So I am really thrilled, you know, distressed for you as a person to have to deal with this $71,000 bill. I don't know what you're going to do if you have insurance that covers some of it, if you're paying out of pocket for some of it. But, you know, one thing I am really country is that people are starting to look at these bills. It's gotten to a point where people are looking at them and saying, I am not going to take this anymore. And I don't think this is Democrat, Republican, or Independent. People are really outraged. Now, the solutions may be very different if you're Democrat, Republican, or Independent, but the outrage is universal in my experience. That's why this series has gotten more comments than any other series in the history of the New York Times, I think.
And the article we're talking about today in this series, As Hospital Prices Soar, a Stitch Tops $500. We'll get one more call in on this. It's Paula from Pennsylvania on our line for Independence. Paula, you're on with Elizabeth Rosenthal.
Well, thank you for taking my call, first of all. And I'm just another one of those people that is trying to negotiate my bill. Well, it's not really my bill. It's my husband's bill. He was in the hospital for 2 days being detoxed from alcohol and drug abuse. And they sent us a bill for, not even itemized, for $23,000. And then when I said that I was paying it myself, they negotiated, well, they automatically dropped it down to $17,000. He was in there for 2 days and just got basically blood tests and one x-ray, and that was it. I mean, and, you know, drugs, of course, like Tylenol, this and that, you know, not expensive drugs. And I'm wondering, how the heck do you get these guys to be reasonable? I mean, I don't want to cheat them, but I don't want to be cheated either.
Elizabeth Rosenthal, in the last 30 seconds we have here.
Yeah, I think this is a really important point. You know, hospitals say they do a lot of charity care, free care, but look at this. You have a bill for 2 days for $26,000. A patient says, I can't pay, I'm paying this myself, and they say, okay, then $17,000. That's still a really ridiculous amount for 2 days of care, I think. So I think we really need a national discussion about what's reasonable in terms of hospital prices, and a way either via the market and price transparency or via regulation to get to a better place, because people are really, really suffering for really basic care. This is not a rare cancer. This is a common medical experience that millions of people are going to need each year.
You can check out Elizabeth Rosenthal's work at nytimes.com or follow her on Twitter at NYT Rosenthal. We appreciate you coming on the Washington Journal this morning.
Thanks for having me.
Mr. President.
Senator from South Dakota.
Mr. President, I ask unanimous consent that the quorum call be dispensed with.
Without objection.
Mr. President, once again I come to the floor to discuss the negative impacts that Obamacare is having on my constituents in South Dakota and to countless Americans across the nation. Since this health care law was enacted in 2010, I've come to the floor on numerous occasions to discuss the number of promises the President made to the American people that have been broken. My colleagues and I have highlighted the fact that the President's promise, if you like your health care plan, you can keep your health care plan, period, simply isn't true. Reports indicate that more than 5 million Americans already have received cancellation notices from their insurance companies, and much of the Obamacare policy has not even been implemented yet. What's worse, the administration knew that they could never live up to this promise. And instead of finding a permanent solution to the problem, they proposed a political solution. Today I'd like to highlight yet another broken promise made by the President that's resulting in sticker shock as many Americans purchase health insurance. While campaigning for the presidency and in speeches leading up to the passage of Obamacare, President Obama promised the American people that their premiums would decrease by up to $2,500 per family. Instead, many families are facing sticker shock. Since enactment of Obamacare, health care premiums have actually increased by more than $2,500 per family, that according to the Kaiser Family Foundation annual survey. As a result, many American families are sitting around their kitchen table trying to figure out how they're going to shift their finances around to afford health care when they were promised their premiums were going to go down by $2,500 per family. As the President has said, this law is more than just a website. Well, we agree with that. Mr. President, this law is more than just a website. This law is a series of broken promises that are resulting in higher premiums, higher deductibles, and higher out-of-pocket costs for middle-class families. Money that families could be using to help pay off student loans, save for a house, or to start a business, those are now going to be used to pay for government-approved health care. Recent reports out this week by the New York Times and Wall Street Journal highlight the fact that deductibles and other costs under Obamacare have surged. The Wall Street Journal reports that the average individual deductible for a bronze-level plan on the exchanges is over $5,000 a year. This means that a policyholder would need to pay over $5,000 in order for their insurer to start making payments. One of my constituents recently informed me that her family's health insurance plan was canceled, and the new policy she was offered would double their deductible to $5,000 per individual. She and her husband have 3 children. In addition to a higher deductible, this family faces higher premiums, higher co-payments, and a higher out-of-pocket maximum. She goes on to say, please explain how this new coverage is considered affordable under the Affordable Care Act. Another couple in my state of South Dakota informed me that in the form of an email that their premiums were going up by $400 a month, and the deductible was going up by $1,400 on their policy. And their question was, what is the federal government doing? And the federal government, the gentleman said, I feel like the federal government just stole $5,000 from me. That's the frustration that people across the country are feeling as a result of Obamacare. The middle class is faced with higher costs while their take-home pay and hours are being reduced. As more and more Americans begin to formulate their family budget for 2014, they're going to learn that yet another promise by the President has been broken. Not only are they losing the plan they were promised they could keep, they're facing sticker shock over the increased cost of health care coverage. This flawed law will continue hitting middle-class Americans in their pocketbooks as the nation's economy continues to struggle to regain its footing. Mr. President, the flawed rollout of Obamacare is no secret. We have all seen what were described as the countless glitches associated with the rollout. But to make matters worse, recent reports indicate that in October, 1 in 4 Obamacare enrollees faced a glitch not many were aware of. This glitch, called an 834 error, has prevented insurers from receiving the proper information regarding people who believe that they had successfully enrolled in a health care plan. In essence, 25% of initial enrollees in Obamacare, after persevering through the errors on a website that was not ready for prime time, may not have proper coverage come January 1 of 2014. What is even more troubling is the fact that the administration estimates that 10% of new enrollees will continue to face this problem. Here we are, 23 days before January 1st, and those who worked through the headaches of healthcare.gov may or may not have coverage. Unfortunately, this administration continues to refuse to seriously address these problems. And even though they have unilaterally delayed several portions of this law from taking effect and have previously failed to meet half of the requirements mandated by the law, the administration will not provide the same relief for the individual Americans as it has for big businesses. Mr. President, this law is fundamentally broken, and we need to start over. Rather than expand the government's role in providing health care, we need to enact policies that make the private insurance market more competitive to ensure that individuals and families have choices when it comes to their health care. The unfortunate reality for middle-class families is their premiums, their deductibles, their out-of-pocket costs under Obamacare are not glitches. They are a harmful reality that is resulting in sticker shock for literally millions of Americans. Mr. President, we can do better. We should do better. This is more than just a website. It is the substance of this law that was built upon a faulty foundation that is leading to canceled policies, higher premiums, higher deductibles, higher taxes, and fewer jobs and lower take-home pay for the American people. This is a direct shot at the heart of the American middle class. The President last week got up and made a speech where he talked about income inequality. And what he should have focused on is the best way to get rid of income inequality is to repeal this health care law. Because what's going to happen to middle-class families and middle-class Americans under this health care law is much higher costs, much lower take-home pay, many fewer jobs for them and for their children, and a lower standard of living and lower quality of life than what they've enjoyed in the past. That will be the impact upon middle-class Americans as a result of this law. Mr. President, I yield the floor. I suggest the absence of a quorum.
Clerk will call the roll.
Mr. Alexander.
Mr. President.
Senator from Louisiana.
Thank you, Mr. President. Mr. President, I take the floor again to discuss...
Sir, we're in quorum call.
Excuse me, Mr. President. Mr. President, I ask unanimous consent to vitiate the quorum call.
Without objection.
Thank you, Mr. President. Mr. President, I come to the floor to discuss what I call the Washington exemption from Obamacare. One of the few real victories for the American people I think we had in the Obamacare debate was we actually got an amendment included in Senate consideration of the bill that said much of Washington, all members of Congress and all of our congressional staff have to go to the Obamacare exchanges for our health care, just like millions of other Americans, and we had to get it there. Now, unfortunately, I guess this was an example of what Nancy Pelosi said when she said, well, we need to pass the bill in order to understand what's in it. Because after the Obamacare statute passed, with that very clear and very specific provision in it, a lot of folks around here read it and said, oh, you know what? How are we going to deal with this? And there was a furious behind-the-scenes lobbying effort that went on for months to essentially get around that provision and the pain it would cause, the pain being subjecting members of Congress and all of our staff to the same circumstance, to the same experience as other Americans. Well, that ended with President Obama getting personally involved and the Obama administration issuing a special rule. And that rule is just an end run around the specific statutory provision. I think it's completely illegal for that reason because it is in conflict with that statutory provision. And one of the key things that rule says is, well, the statute says all official staff go to the exchange, but, you know, we really don't mean that. And so we're going to leave it up to each individual member to decide what staff are official, what staff go to the exchange or not. And as a result, there's a huge loophole that some members are using to exempt much, in some cases even all of their staff, from going to the exchange as mandated clearly by the Obamacare statute, so that we have to walk the walk of other Americans, so that we have to share in that experience. Sadly, the distinguished majority leader, Mr. Reid, is one of those members actively taking advantage of that loophole and exempting much of his staff, according to press reports. And because of that, I've written the majority leader today and asked him to answer some very important and straightforward questions about that situation. And so I think to make this point, I'll simply read this letter into the record, and was sent to the distinguished Majority Leader in the last several hours. Dear Majority Leader Reid, it has been reported that you are the only member of top congressional leadership, House and Senate, Democrat and Republican, who has exempted some of your staff from having to procure their health insurance through the Obamacare exchange as clearly required by the Obamacare statute. Millions of Americans are losing the health care plans and doctors they wanted to keep and are facing dramatic premium increases, all as Washington enjoys a special exemption. Given this, I ask you to publicly and in writing answer the 4 important questions below regarding your office's exemption. I will also be on the Senate floor to discuss this at approximately 4:15 p.m. today and invite you to join me there. First, how did you designate each member of your staff, including your leadership staff, regarding their status as quote-unquote official, going to the exchange, or quote-unquote not official, exempted from the exchange? Did you delegate that designation to the Senate dispersing office, which would have the effect of exempting all of your leadership staff from going to the exchange? Second, if any of your staff is designated as quote-unquote not official, exempted from the exchange, are any of those staff members receiving official taxpayer-funded salaries, benefits, office space, office equipment, or any other taxpayer support? Third, if any of your staff is designated as quote-unquote not official, exempted from the exchange, did any of these staff members assist you in drafting or passing Obamacare into law? If so, which staff members exactly? Fourth, how are the above designations of yours consistent with the clear, unequivocal statement you made on September 12th? Quote, let's stop these really juvenile political games, the one dealing with health care for senators and House members and our staff. We are going to be part of the exchanges. That's what the law says, and we'll be part of that, close quote. I look forward to your clear written responses to these important questions. I also look forward to having fair up or down votes on the Senate floor on my show your exemptions and no Washington exemptions proposals in the new year. Sincerely, David Vitter. And I ask unanimous consent, Mr. President, to submit this as part of the record.
Without objection.
Thank you, Mr. President. So, Mr. President, that lays it out clearly. I think this is an important debate that the American people care about. As I said in the letter, millions of Americans